So let's see. I hope, people are coming on already. All right, this is Dr. Tofi. Let's see. We have some familiar friends on this. I'm joined here today with Dr. Brian Jacob. He is a hernia specialist like me. We share a lot in practice. We're on each of the two coasts. I'm on the West Coast and he's on the East Coast in Manhattan. And just a little bit about let me share my screen here so you can all see. You are now all watching HerniaTalk Live. It's our second every Sunday episode. And basically what we are going to do is spend 1 hour talking about all of our hernia questions. I am Dr. Tofi. I have a practice that's completely hernia related in Beverly Hills, and you can follow me. We are currently live on Zoom and also live streaming on Facebook on my homepage. And we are very gifted to have Dr. Brian Jacob. You can follow him on Twitter at NYC Hernia. He is a esteemed top hernia specialist, good friend of mine, who practices out of Mount Sinai. And you want to say hi, Dr. Jacob?
What's up, everybody? Brian Jacob here from actually New Jersey right now in my house. And Dr. Tofi, thank you very much for having me live today. It's amazing to be here. It's amazing what you're doing for the patients that are out there. And I hope everyone's staying safe. I do see some familiar names. And so hello to those who logged on that I know. It's great to see you again.
I didn't know you live in New Jersey.
I do live in New Jersey. New Jersey is a commuter town to New York. It takes about 25 minutes during these COVID times when there's no traffic.
Oh, okay, that's good. Yeah, I don't live in Beverly Hills either. I live in Los Angeles, but you know.
Yeah, with non-COVID times, I'm looking at about a 45-minute drive.
Are you seeing a lot of COVID? Are you working at the hospital doing COVID stuff a little bit?
I'm drafted. I'll start this week to help out on the front lines. Yep. So my routine practice is currently paused, and I've been converted into an ER/ICU attending just to help out with the volume until this thing passes, which hopefully will be in the next 2 to 4 weeks.
Yeah, I think it's, as surgeons are used to saving lives. That's like why we go into surgery, because we want to save lives. And yet during an infectious disease pandemic, it's really the medical doctors and the intensivists and critical care and ER docs that are most valuable right now and putting their lives at risk.
Yeah, I'll tell you, I'm late to the game, but there's been a ton of our colleagues who've been out there working really hard already for the last 3 or 4 weeks. So my hat's off to them and to everybody else who's been really working hard, trying to keep things going, while the world is on pause.
Okay, well, thank you for donating your hour with us. We have questions that come in live, and I also have some pre-prepared questions from people who have sent me hernia-related questions in the past week or so. So let's go into it. This is going to be 1 hour. For those of you, if you want to take notes, know that this will be then posted. You can follow it as a Facebook Live on my Facebook homepage or on YouTube. The full hour will be uploaded. So let's go with our first question, the Q&A. This is from Daniel Hauser. He asks, I had a TAP laparoscopic double hernia repair with mesh. The second opinion surgeon says he prefers TEP, TEP. So he had a TAP, his second opinion surgeon prefers a TEP. Is one easier to recover from, and what's the difference, Dr. Jacob?
Yeah, so I hope I wasn't the second opinion surgeon because I'm a TEP surgeon.
Me too, I'm a TEP surgeon too.
Yay, TEP.
Yeah.
No, I don't think one is easier to recover from than the other. I think when the surgeries go well, the recovery should be about the same. It's hard to compare recovery between the two because most people will only fall into one group or the other. But I think in general, I wouldn't tell a patient that one was easier than the other. It's just my 2 cents. What do you think, Dr. Tofi?
I mean, sometimes you have to convert, right? I would say maybe 99.5% of the time I can do it TEP, but every so often you have to convert to a TAP, T-A-P-P.
Yeah.
And the robotic era, it's all TAP. I don't think, I think people have tried to do a robotic TAP. It's very difficult. So it's all TAP, T-A-P-P. And just to review, the main difference, TEP stands for totally extraperitoneal. TAPP stands for transabdominal preperitoneal. And it's just how to access the hernia. Do you cut through the peritoneum or you don't cut through the peritoneum? And everyone has their own style. It's like saying, do you like, Nike or Adidas? Do you like high tops or regular tennis shoes? They both
That's
function.
right. It's surgeon preference, but from a patient's perspective, there was a time not long ago where we would just tell them we were doing it laparoscopic, and there was not a tremendous amount of discussion about whether we were doing a TEP or a TAP, because in the end, it's the same operation. From the perspective of the hernia and the body, it's pretty much the same operation. There's some very subtle differences, but recovery, and everybody owns their own recovery. To each person, that word, what's recovery like, means something slightly different. But in general, recovery is about the same. And by the way, just because I can't tell, am I coming through clear?
You are coming through clear. I want to see, okay, I just want to double check that we're going live. Go live.
That's great.
So I want to make sure that we're going. Live on Facebook. It wants me to add things, but I don't think it needs anything. We're having problems with the go live. I'm going to try the go live one more time. So you guys, you want to talk, Dr. Jacob, while I figure out the go live part?
Not a problem. So for those attendees that are logging on now or recently, my name is Brian Jacob. I am a general surgeon specializing in hernias. I am working in private practice in New York City. I am an associate professor at Mount Sinai, and currently the hospital is been diverted as an emergency hospital. We're taking care of COVID patients. So my practice is on hold, but I was invited tonight by Dr. Tofai to talk about groin pain and hernia. And the main purpose is so that I'm able to help answer your questions as opposed to just talking continuously. What's up, Desi? I see Desmond Hun is out there. Desi started his journey back as a medical student at Mount Sinai. It's great to see him growing up, become a big surgeon like he's going to be. My practice, I see about 3 or 4 new chronic groin pain patients every week now. I didn't start off my practice like that. And I think Dr. Tofai and I agree that, when patients come in with a chief complaint of groin pain, it's a whole new ballgame. This is not something that I ever appreciated as I began my practice, but groin pain deserves a lot of attention and a lot of listening, because the answer to helping people with groin pain is usually in the story. It's in the description of the pain and when it started, where that pain spreads to, how long it's been there, what makes it worse, what makes it better.
We're good. All right, let's see if we have more questions. Let me share my screen with you. We lost Dr. Jacob. There you are.
Hello.
All right, we got you back. Okay, so we're going to start with some easy peasy questions, and then we'll go to the harder ones. Next question. I have a minor hernia. Is it still okay to work out and bodybuild and do ab work?
Yes.
Yeah, yes, I agree. Why is that?
I have a minor hernia. Is it still okay to work out with my? Well, look, just because you have a hernia doesn't mean you can't live. I think there's a interesting philosophy out there that once you have a hernia, you live in fear of needing an emergency surgery, whether it's minor or major. And that fear is probably the result of dogma from before you and I went into practice. I do think a lot of people with hernias were told that if you don't get it fixed soon, you may strangulate. And I just think that the risk of that happening is pretty low in general. And so I can say, even not only as a doctor, but someone who's living with a hernia, a minor one, that you can live a very long time with minor hernias. You can work out, you can run, you can lift, you can dance, you can do Pilates, you can do yoga. And as long as it's not getting in the way of your ability to do those things, it is safe to do those things.
And I know you can do it, but do you recommend that they do it?
Sure. I mean, I don't,
Have you ever
again,
had anyone come to see you and say, I was at the gym and now I'm in the emergency room with an incarcerated hernia? I've never had that.
yeah, can you repeat that again? So they were in the gym.
Working out, bodybuilding or doing abs, and then they all of a sudden incarcerated or strangulated and had to come to the emergency room. I've never had that story.
Never had that. Never, ever had that. So here's the other thing. You can have a minor hernia and still hurt yourself. You can still sprain the conjoined tendon or the adductor or the inguinal ligament or the iliopsoas tendons in that area. And this is like the lethal combination, because you get a groin sprain, which you and I, label as a specific tendon that's injured. Some other people label it as sports hernias. Some other people just label it as a groin sprain. But if you came in with a hernia and a groin sprain, everyone assumes that if you fix the hernia, you're going to fix the pain. And that's when you get into trouble. Because now you've fixed the hernia, but the hernia wasn't the thing that was causing the pain. So especially when someone comes out of a gym and tells me that they have a new symptom, that is the time to at least do a really good physical exam and get an MRI before you operate. This is just my 2 cents, it's my opinion, because you want to document it if there's any fluid or edema around the groin to show that there's any minor injuries.
Yeah, that's a very good point. Very good point. In that just because you have a hernia doesn't mean the groin pain is being caused by that hernia. A good history and physical exam and some imaging sometimes can help rule out something different, like a sports injury.
Yeah, I'll give you an example. So again, I've been living with a hernia for a long time. It just never bothered me, and I was in the ocean. And you know how when you're in the ocean, you have to stabilize yourself against the waves? It's almost like you're surfing as the waves are coming in, like near the shore. And all of a sudden, I felt this horrible pain. It literally started near where the hernia was and went down my leg a little bit. And it dawned on me, I'm like, wow, this is why people think hernias are so bad, because the pain was actually pretty bad. But I knew it wasn't from the hernia. I knew I had pulled something. I took some Advil. It took about 2 weeks and the pain went away. Still have the hernia.
Yeah.
So it was a good lesson in the symptom for me.
Plus, what I tell my patients is we've actually looked, this is an old study now, it was a new study back in the day, and basically they looked at what happens to abdominal pressure when you do sit-ups, deadlifts, and coughing, and burpees, squats. And what they found was that, doing a sit-up, for example, or deadlifts or overhead lifts, pull-ups, those didn't really cause a lot of abdominal pressure increase. Coughing and straining to have a bowel movement, that's so much more pressure. So if you think that hernias are caused because you have abdominal pressure increase, most exercises do not cause that increase.
Agree. So to the person out there who asked if they can work out, the answer is absolutely. The other thing just to point out, you don't really need surgery until the hernia that you have is preventing you from doing the workouts that you want to do.
Yeah.
And that's sort of how I help patients decide when it's the right time to do it. If it's in the way of your daily life or your routine workout, then fix it. And don't be afraid of mesh in that situation, because you will feel better after you get a hernia fixed. If it's done correctly with mesh, but only if it's getting in the way of your workouts.
Okay, we have a question about chronic pain, which I know you treat a lot of.
See Josh's question.
Josh's question. Josh had 5 hernias fixed October of 2019, 1 left side direct inguinal hernia and 1 left side indirect. So on the left side, he had a direct and indirect. He He also had an obturator hernia on the left side, so that's the 3 he's referring to. Then on the right side, he had a direct and I think the right side also indirect hernia, all fixed laparoscopically with mesh. Sounds like the right thing to do. I'm still having horrible chronic life-changing left-sided groin pain in the adductor and inner thigh, medial to the sits bone, ischial tuberosity. Well, that's way deep. No one can give me answers. I don't know if it's a nerve issue, pudendal or obturator, or an adductor tear, but I'm in really bad pain and I need help and answers, please. So this is basically a patient. He had bilateral inguinal hernias and therefore had a laparoscopic repair. I think we would both agree that's the best option for the average patient, correct?
Yeah, but let's go back to, there's a key word in there. I know you and I are going to focus on it.
Mm-hmm.
Right. The word that I see he typed that I need to go back to and ask him more questions about is the word still. So, Josh, I'm still having horrible chronic life-changing pain. So did you show up and tell this surgeon that you're having horrible chronic life-changing left side groin pain? What did you present with before you had the hernias? I mean, that's where I start that interview. Because there's one of two things. This pain is brand new after the guy woke up, or he came in with this kind of pain and had hernias coincidentally that weren't the cause of the pain. And those are the two algorithms. Would you agree? I
agree. It's a lot of detective work. So did you have the pain? You had surgery, you still have the pain, which means it wasn't hernia-related pain usually. Or did you have the pain, you fixed the hernia, that pain is gone, right? And now you have new pain. And so then we got to figure out, whether the surgery caused that. So Josh, if you don't mind, give us some answer to that, and then we'll figure it out. I don't like to bring in pudendal nerve into the picture. I feel like that just adds extra complications. People don't just wake up with pudendal nerve, and for sure, we cannot injure the pudendal nerve during hernia surgery. So
correct.
That diagnosis, I think, is thrown out a lot when people don't know what's going on with chronic pelvic pain, and it's very rarely the problem.
Yeah, for sure. And, that's, the other thing is when, patients like Mr. Weston start talking about adductor and ischial tuberosity and pudendal and obturator nerves and adductor tears, you're obviously an educated patient. You've been reading up on the possible causes of groin pain. So there's a lot more to that story. See, there you go. All of my pain was there before my surgery. And so that is so key to every single person. And to be honest with you, it's for a surgeon to assume that severe of pain was from a hernia, that may have been one of the oversights. So yeah, Sherwin, they did the right operation. I mean, there's no question. If you had hernias, love the laparoscopic repair, but it didn't fix the cause of Mr. Weston's pain. So we're not going to blame the surgery, but we got to go back and start over. So the next question, I don't know what you asked, Sharon, but, I want to know when that pain started, right? How many years did you have that pain? What were you doing when it started? I get this lecture at Sherwin's seen. It's all about you, Josh. You came in with a severe amount of pain. We got to dive into that. So your story about that pain is going to help us figure it out. And then I'm getting an MRI on you at some point.
Absolutely. Yeah, that's definitely the next step.
Sitting in adductor since March.
Plus the physical exam, I think, is very important to help figure that out. Dr. Jacob, if someone wants to see you, either during this COVID pandemic or afterwards, how could they contact you? Should they go on Twitter on your account and figure it out for you?
Why don't they email me and we set up virtual consults. So I use the same platform. I use Zoom. My office will help process the information about that consult. And then we do a Zoom consult. And then when life gets back to normal, I'll be seeing patients in the office again. So the Zoom, as you know, we can do a lot, but we can't do a physical exam. So when it comes down to it, we still someone's going to have to do a physical exam here. But yeah, that's how they do it. So the telephone number for my office is 212-879-6677, or they can email me, which is nychernia@gmail.com.
Okay, so very important. I know you had mesh in you. the fact that you had the pain before surgery, and if that's been unaddressed with the surgery, likely, like, please don't go and just get your mesh taken out. You're
No,
going to
definitely
have
no.
the problems. So see Dr. Jacob or to help figure that out for you.
Yeah, no, you don't need mesh. Mesh removal does not cure pain if mesh implant did not cause pain.
Yeah. Okay,
Sure.
another question. I know we have some questions on Instagram, but I will go to the Zoom question first and then we'll move to Instagram. So the question is, about 2 weeks post-op, I sneezed, which we know causes a lot of abdominal pressure, and had tremendous nerve pain. It went away after 10 days. CT scan showed nothing, but I've struggled with recovery 10 months. Any correlation? What do you think?
Well, I would ask you, same sort of thing. I don't know if it's a woman or a man, but post-op, what operation are we talking about? Need a little more detail there.
Patient. I think I know this patient. I don't remember what type, but it's male.
But open inguinal, robotic inguinal, lap inguinal, ventral. Long story short, should you still be struggling 10 months later? No. But again, then we would have to go back and figure out what exactly the struggle means. It's missing a lot of information to sort of address it. But all we can say is, without knowing your operation, by 10 months, you should be not knowing you had an operation.
Yeah, that's true.
That would be fair about, and so more about that. For the audience out there, the theme about a lot of these specific presentations is going to be, how well did the surgery that was done address the chief complaint when you showed up at your surgeon's office? And this, for me, my plea is, like, just because you have a hernia does not mean you need to fix the hernia. You fix the hernia when the hernia hurts. And then, so these questions are easy when it's post-op hernia pain. They're much harder when it's musculoskeletal injury treated with a hernia repair.
Lots of questions.
So Anonymous, let's get some more detail from you.
Lots of questions on Facebook Live. First one is male patient. I had a left-sided inguinal hernia containing peristalsing bowel that caused me burning, aching pain from October to late February. It would get away, but it would be better. Since February, I've had sometimes constipation and different types of stools. The old hernia pain doesn't happen anymore. Could the two be related? So can bowel function be related to your hernia, especially if you know there's intestine in your hernia?
I don't know about bowel. I mean, how much intestine, right?
Yeah, yeah.
We're talking about a big loop that's partially being squeezed.
Well, it's inguinal. So unless it's enormous, right? Usually we don't have a lot of bowel function changes with a bowel hernia. That's just a typical one, right? So the same question, same person asking the question is, could my inguinal hernia possibly be pushing or constricting my bowel in some way? So usually I would say not, unless you have a lot of pain associated with it. If you have bowel that is entrapped, if you have bowel in your hernia, then the chances that that's causing any problem with no pain is very low. If you have bowel in your hernia, but you have pain, some type of like burning pain or anything that you would think is either incarceration or strangulation, then yes, I would be worried that any bowel changes would do that. But that's an acute problem. That's usually a problem that occurs within minutes to hours and doesn't go away. And you need some type of emergency medical care for that. If it's a long-standing problem, I would say that there's little to no reason that the hernia is in any way narrowing or constricting your bowel. Now, the reverse is true, which means if you have constipation baseline and you're pushing and straining because of your constipation, that can make a hernia worse and it can make your hernia symptoms worse. but the reverse is usually not true unless it's an acute problem where you have to end up in the emergency room. So I hope that helped in your questions. I've scheduled a hernia repair for May, colonoscopy in June, so May, June. So colonoscopy after your hernia repair? Could my hernia possibly be related to a change in bowel movements? I think we answered that. In general, just so people know, colonoscopy is safe to perform if you have a hernia, unless there's an enormous amount of bowel in your hernia, and large bowel, colon in your hernia, in which case you maybe should not do a colonoscopy. Your gastroenterologist should be able to help figure that out. But in general, it's safe to have a colonoscopy even if you have a hernia, especially if there's no colon in your hernia, which is almost always. Okay, another Facebook Live question. I see other questions coming in as well on Zoom. We will make sure we get to that. And I think Dr. Jacob is working on his internet issues, so hopefully we'll get to him soon as well. So another male patient. For men with a very enlarged prostate, does open surgery make more sense than laparoscopic if prostate surgery is needed down the road? Thank you, Doctors Tofi and Jacob. Okay, very, very good question. Short answer is no issue, because the urologists now do robotic surgery for their prostate, and almost always a prior hernia repair is a non-issue. So it used to be that we were doing laparoscopic hernia repairs and the mesh was going in the same plane where you have to dissect the bladder and the prostate for prostate surgery in open surgery. So in open surgery, they'd go in and they'd be like, we can't even get to this, we can't even find the prostate because there's mesh and inflammation in this area. So Dr. Jacob, this is a great question. So is it okay, if you have an enlarged prostate and you think you're going to need prostate surgery, and you also have a hernia and you want to get the hernia fixed first, should you choose open or laparoscopic, or does it not matter?
Debatable depending on the experience of the people getting involved. We at Sinai will offer two things. One is we offer simultaneous, which is, I don't know if you offer that as an option, but a lot of times when they're doing the robotic prostates, a member of my group will come in and fix the hernias with mesh. And we've not found in the last 2 years there to be an increased risk of infection. This risk, this fear has been a huge concern of ours, and it just hasn't panned out to be true. So simultaneous repair is an option. As far as getting it done first.
Robotic, correct? Let's just clarify that. That's robotic repair. Yes. So the prostate is done robotically, and then you go in robotically and also do the repair at the same setting. Is that correct? So just to clarify, that's robotic surgery.
Correct.
Correct.
Yes. Are we talking about robotic surgery or no?
He's asking, he's saying, you know, I may need prostate surgery, and I'm going to have my hernia repaired scheduled. Should it be lap or open, or does it matter?
Yeah, I really think that it is based on the experience of the people involved. So you got to talk to the first thing is talk to the prostate surgeon. And the second thing is to say to them, you know, what technique are you using? If they're doing robotic, my next question is there a robotic hernia surgeon that can come in and fix them at the same time? If you're going to have your hernias done first and you're planning a robotic prostate, then all you have to do is make sure your robotic prostate surgeon is okay dissecting after there's been mesh in there. The unanimous answer has been they don't mind it. It doesn't seem to bother them.
Right.
You know, it's sort of academic to say that the mesh there is a problem. It just doesn't seem to be an issue. So I think they're both going to be fine in that situation. The old-fashioned answer though is, oh, you're going to be in that plane for your prostate, just get it done open. And I think that's great too. Like, hey, listen, if your hernia surgeon is really good at open Liechtenstein or open Schuldeis, then get it done open.
So it used to be
Yeah, I'm sorry.
a urologist when they were doing open prostate surgery, they had, some of them could not do the surgery because there was a laparoscopic mesh in the area. But in the United States, 98 or 99% of prostate surgery is now done robotically. And we looked at our data at Cedars-Sinai to see if people who had robotic prostate surgery were able to get laparoscopic inguinal hernia repairs. Yes. And if people who had laparoscopic inguinal hernia repairs could then get a safe robotic surgery. Yes. So in the robotic era of prostate surgery, we've noticed that, obviously with a skilled surgeon, that they didn't have any problems doing the prostate surgery if there was mesh there in the past. If you're having open prostate surgery, that's different scenario. And like I said, 98 or something percent of prostates are done robotically. So do whatever you think your surgeon is best at for your hernia repair. It should not affect your prostate surgery because almost everyone does it robotically now. I hope that's helpful. All right, we have a long question from Zoom. One of two. Okay, I'm going to read this. I had a left inguinal hernia repair laparoscopically in 2008. No pain before surgery, but I did have surgery and it took a year to get the surgery. So that's 2009. By this time, every time I stood up, my intestines would fall through the hernia unless I held it up with my hand. So large scrotal hernia sounds like. The only way to remedy this was to lay down with my feet and pelvis elevated until I heard a gurgle and felt my insides shift. So reducible hernia. The surgeon said in all his years of doing this surgery, I was the second largest opening of the inguinal ring he had seen, and he almost couldn't repair it inguinally. The surgery took more than twice as long as it should have. After the surgery in the recovery room, I couldn't urinate for 5 hours. That happens. I kept drinking water and felt it could, I had to explode, but couldn't. So that's called urinary retention. It happens especially with many open operations or laparoscopic. When I finally went, they let me go home and I had to pull over to pee again. Over the years, it took me longer and longer to empty my bladder, sometimes up to 45 minutes. I also get shooting pain across my lower spine to my anus. All these years later, I've seen many doctors and specialists, MRIs, no answers or help. The only thing that helps me is to eat a mostly raw diet, which is high in water and easily digestible. When I eat more cooked foods, I feel that my GI tract is painful until I pass the food. Also, when something is irritating my bowel, my bladder pain, continuous feeling of needing to urinate, intensify until the food is passed. I still have to lay down. Okay, this doesn't sound like it's a hernia-related problem. I feel things move up my pelvis and back into place. What tells me to do this is a pinching feeling in my anus that gets worse the longer I stand up. I mean, this was an open hernia repair.
Yeah, whatever's going on isn't related.
Yeah, sounds like you have an enlarged prostate, and that was probably what made you higher risk to go under urinary retention to begin with. And now you have a slow urinary stream. I would for sure get that treated optimally before delving into anything else. Imaging maybe can help to see where the mesh was. I would have to, if it were me, I would look at your opera report to see what they saw and where they put the mesh. Sometimes they put the mesh, retroperitoneally, or there's a plug that maybe can cause adhesions, but
the only thing I can think of in this situation is sometimes a diagnostic laparoscopy helps to kind of confirm that the open repair didn't do anything.
Big sac, maybe that sac when it was pushed back in is like
stuff gets stuck, it pulls on stuff. When we do laparoscopy robotics, there's a ton of information our brain gathers just visually that you'd never get during open. And so one thing I've learned in this business of chronic pain is nothing's textbook. Nothing's textbook. And this is where I think, Sherwin, you and I agree, where a lot of surgeons maybe just don't want to do a diagnostic surgery, looking for possible causes of pain. I'm willing to go there. And so in this situation, look, I don't know what's causing a pinching anal pain, right? I would bet it's not related, but if I put a laparoscope in and there's nothing there, then it's not related.
What about, okay, so the clarification is it was originally a laparoscopic repair. Does that change your answer?
Not really.
Yeah.
Not really. I mean, just go look. If there's nothing visibly wrong, then not. You know, so there's one other slight cause of chronic pain that we didn't discuss in this guy's case, but that is when the mesh that we put in shrinks and it can pull on tissue, and it will look visibly normal. But because it's got this chronic pulling to it or clamshelling to it, it's pulling on the tissue surrounding it. That wouldn't cause this patient's symptoms in this case. But you could argue in certain other cases, if they presented with, chronic pinching pain every time they sat, that's a hip flexor maneuver. That's putting the iliopsoas and the flexor femoris on tension. And if those are already on tension from mesh that's shrunk, it'll exaggerate. So in those patients, you can remove mesh and say that they would have about a 50% chance of a cure, but a 50% chance of having no symptoms and just getting the hernia back.
So I would say that if you were to see me, I would first look at your operative report to see what technique was used, tap or tap we discussed, and also what size mesh was placed. Did they put like an enormous piece of mesh, which went down way too low and now is affecting some of those pelvic floor muscles? And also look at your imaging, not just to see if there's a hernia recurrence, but to see if I can, on MRI, often you can see the mesh and see if it's placed lower than usual or more medial than usual. Those are all like little details of the repair that we need to kind of figure out to see if any of those symptoms are related. And I agree with Dr. Jacob, which is it's not cool to live with these symptoms and just say, well, imaging doesn't show anything. Oftentimes surgery is worth doing, because if we find something that we can fix and repair, that can completely change your life quality and with low risk. So I have a low threshold to offer a wide variety of interventions as long as the risk-benefit ratio is there to help patients finally get a cure for their symptoms. Agreed?
Yeah, as long as, and I agree in short, but it takes a little bit of time to get the patients on the same page as us.
Mm-hmm.
And more specifically to make sure they understand that the surgery is not necessarily a cure, but a diagnostic tool in that situation.
So going back to the gentleman who had his laparoscopic repair and then 10 months later he's still struggling, the question is, he still gets sore when he's active, but it's more of an annoyance than a huge life-altering problem. So he's been doing PT, etc. At what point would you consider revising his repair? I mean, that's a high-risk procedure. Yeah,
what does revise it mean? Anytime someone's complaining of the same thing for 12 weeks after surgery, I start considering revisional surgery.
Mm-hmm. 3 months, yeah.
3 months. It doesn't mean I'm going to do it. It just means I start thinking about it as an option. You and I shared a patient once, my own case. And if I had followed my own rule, I would have removed a mesh after 3 months because I did a surgery and the patient had, what he believed to be new chronic pain that kept going and going and going. I really had to search for a cause, and the MRIs kept telling me things were normal, but the symptoms very much were about the sitting. Sitting hurt. It was in one spot, mostly sitting, sometimes in a car, when sitting in a car for a long time, stepping on the gas. And I basically had to start doing sequential diagnostic injections into the different tendons that cross that area, just to see which one, when injected, would get relief. And that took a lot of buy-in from the patient. I give him a lot of credit for working with me, but I simply didn't want to just take out mesh after 3 months, even though the pain started after surgery. We were able to find out that the patient had an unread iliopsoas bursitis. And so we did 2 injections, and thank God the pain went away. So I didn't follow my own rule, but I label these people, these diagnoses, as chronic pain after 12 weeks. And
yes.
You got to go into overdrive, and you really got to start figuring out.
There was, I don't know if it was a paper or some discussion in the hernia world that got out to more of the community surgeons that you got to wait 1 year. And I very much against that. I think for minor aches and pains, 1 year maybe fine. I've had my own operations before, and I still have little twinges where the surgery site was. That's okay, but to have severe life-altering chronic pain and say you have to wait a year to see what happens, I think that's not right.
That's correct. Okay.
This is a good question. Again, in the chronic pain realm, I've read statistics ranging anywhere from a set of hernia operations can result in chronic groin pain. In your experience, what do you think the real world percentage is? And will a patient always have a weakness or discomfort from the operation, or can one be completely cured and pain-free?
I read the same thing. I think I read the same stats.
Yeah, the numbers are everywhere.
I think real world percentage is never the same as the statistics.
Yeah.
I don't know any surgeon out there who has a chronic pain rate themselves more than 1%.
Yeah.
You know what I mean by that statement? So if combined, we all are quoting 1%. But listen, I know surgeons who quote 0%. You know, my hat's off to them. I think that the real statistic is about 6%. There's a really very honest academic surgeon named Dr. Todd Henneford. And he put a lot of effort into trying to figure out what this real world experience looks like. And the number that he came up with on his app is about 6%. Normal non-pain patients develop pain after hernia repair. And he doesn't actually believe that every surgeon has a 6% rate of chronic pain, but he says it's a good conversation starter. It at least engages the patient in the concept that they may get pain that they don't have before. But in general, if you go to somebody and they do the surgery that they do all the time, repeatedly, and this is not, you know, a new surgeon who just started, but someone who's been doing it for, let's just say, at least 3 years straight, 4 years straight, you're really going to have a very low chance of chronic pain if you have the same surgery done to you, and it's not a complicated case. And I would feel confident saying that for everybody. I think that where some surgeons get into trouble is when they utilize a technique that they don't need all the time, or the case is so straightforward that they don't realize that the mesh folded. So, you know, things happen. But I would say the real world experience is somewhere between 3 and 6%.
So I think the goal is for the patient to, in fact, have a complete cure and be pain-free. I disagree that hernia repairs cause weakness. That's not something that as surgeons we believe. I know that's been talked about in public, but that's not true. You can get discomfort. There's scar tissue, there's inflammation, there's sutures. The mesh, if you have mesh, the mesh doesn't stretch very well. If you don't have mesh, now you're tighter in the area. So there's a lot of pros and cons to every procedure, which may cause discomfort. That discomfort should not be life-altering. And if it is, it's in that kind of 6% sounds like right. I think in a lot of our talks, we hear 12%. And remember, that's at 3 months or longer. So after 1 year, that number needs to drop down. And unfortunately, there's a wide variety of hernia surgeons out there. There are general surgeons that do hernia repairs, as well as breast surgery and gallbladder surgery. And there are those of us like me and Dr. Jacob. My practice is 100% hernias, and we both have a special interest in hernias. Then there's urologists and gynecologists who I know have done hernia repairs, and you know that's what they know, and even plastic surgeons. So what they know and do is very different than our training. So do your homework, and you know, surgery. I don't care what the surgery is. You should always get a second opinion if you can, because you know, you learn a lot from second opinions.
Yeah, for sure.
Okay, let's go to Facebook Live. Question is, what is the success rate for abdominal and inguinal hernia mesh removal?
We just looked at our numbers. They're not as great as I want them to be. And we can talk about this. So this is an evolving field. I think there's about 20 surgeons in the country doing this primarily in their careers now. And I would say that we've been quoting anecdotal numbers. But when you look at it, I would say that the cure rate is somewhere between 60 and 70%.
Hmm.
I don't think it's 100%.
No, I don't think anyone's shown 100%.
No.
Yeah.
It's
We
about
looked at the numbers.
70%.
Yeah,
And it depends when you look at the numbers too.
yeah. And what you define as success.
Correct.
Yeah. I think so we looked at our numbers, and we remove mesh for different reasons. If it's removed for as part of a hernia recurrence or a meshoma, like a mechanical problem where the mesh is balled up, that success rate's very high. In ours it was the 90 percentiles.
Mm-hmm.
If you're removing it because there's chronic pain and there's weird reactions, nerve pain, something that's not mechanical but affects your body a little bit more, that was in the high 70s. So we averaged like in the kind of mid 80s with our percentile improvements.
Yes.
And the good news is that's a pretty high number. It's better than 50-50.
Are we talking inguinal or ventrals?
I'm talking inguinal.
Okay.
But for ventral, I think the numbers are much better, don't you think?
Much better. No, that's what I'm saying. My ventral explants, the numbers are much higher.
Yeah.
I looked at my numbers at a year out. And, you're talking about a cure. You asked if they were cured. So improvement is also a different category. So I do think that almost 90 to 100% are improved when the problems from their mesh in the groin.
Yeah.
But cure rate, 80% is pretty good. If you're getting 80%, then, we have to break down the cohort and see how.
Correct.
When did the pains, like you said, mesh plugs, different ball game than lap mesh. Mesh plugs to me are slam dunk. I love when a mesh plug pain comes in.
I know, it's so gratifying.
Right. Not the patients out there with mesh plugs, most of them are non-causing pain, but the ones that do, when they come out, you're going to get better.
It's like having a little pebble in your shoe. Just take out that pebble and it's like night and day.
That's right. That's right. The most common operation, by the way, in our country is the plug.
Yeah.
Although that may be different now with robotic taps.
Yeah.
Robotic taps may be more now, but I would say up until about 2 years ago, most common operation, 30% were plug and patch.
Yeah, I think the plug was the most common, most sold mesh appliance, right?
Yes.
Yeah. So last week, there was a question asked of me, which I answered, but let's see what the answer is for you. So what are some bizarre or uncommon adverse reactions you've seen with patients who've had inguinal hernia repairs with mesh?
So that's easy because this falls into the category of foreign body reaction. And foreign body reaction, there's no limit to the symptoms. I will tell you that the most unique symptom that legitimately got better after mesh explantation, this one patient had 2 symptoms that both got better. One was hot-cold sensitivity, and the second was light sensitivity. Now, I don't have a way to prove it, but this patient and his wife would testify that after the surgery, the patient had to start wearing sunglasses. He was always cold when he shouldn't be. Thyroid normal, hormones normal, no known cause. The patient himself was just utterly convinced it had to be the mesh implant. CRP normal. Sharon, I don't know if you send these kind of markers, but I look for like subtle changes. Everything was normal. I said, okay, look, I'll take it out. I don't know. We took it out. The symptoms disappeared within a week. Now, I don't have a way to prove it, except for the patient himself and the wife. I don't know why they would make it up, but that's the weirdest symptom I've had get better. How about you?
Yeah, I've sent ESR and CRP, and I've never had one positive. They've always been negative. So I've stopped testing, honestly. Sometimes they come with me with those tests already,
right?
But I haven't found any usage in any of the inflammatory markers, even though systemically they're showing me inflammatory results.
Yeah, for sure.
I've had, rashes, visual changes, ringing in the ear. I've had those, and they all go away.
Yeah.
The most common, like brain fog and joint pain and
Chronic
chronic
fatigue.
fatigue. Mm-hmm.
Listen, if there's a symptom out there, it's possible. But this is a word of caution to the public. Mesh is not bad. Mesh doesn't cause these symptoms in the overwhelming, huge majority of patients globally. The problem isn't mesh. The problem is when there's a patient who's having a problem from the implant, them not getting listened to appropriately. And so we need to raise awareness that the symptoms are possible and not to dismiss them. We all saw, acute redness of the abdominal wall after ventral hernia repairs in very rare numbers of cases, but they're not infections. There's some sort of reaction to the implant. You take the implant out and they get better. I think I posted one case in 2015 on the International Hernia Collaboration. They're rare. They're really rare, but they do happen for lots of different reasons. So I don't think that we need to be slamming mesh, but we do need to be slamming our ability to listen and keep an open mind to the possibility that the symptom is related to the implant. Not that it will be cured when it's removed, because all patients need to understand if they're going to have mesh removed, that symptom may not go away, and you need to be okay with that. But surgeons like Dr. Tofai are willing to take out mesh because you believe it, because we believe it, but it may not help the symptom. I think that's important to throw out there.
Yeah, I think we have to be humble and understand we don't know as much as we think we know. And most important is to believe the patient. They come with very similar stories, and just believe them and help them in any way you can too. And if that involves mesh removal, obviously we don't do it willy-nilly on everyone, but it is a risky procedure, and it should be done by only those of us that do it on a regular basis. But it does potentially can have life-altering improvements in someone's health. Sure.
You see the question about a recommendation. I don't know that I give recommendations online like that. There's a question about a mesh removal surgeon in South Florida. There are surgeons in South Florida and Florida that remove mesh. I'm sure Dr. Tofai can talk to you offline about them.
Actually, if you go on HerniaTalk.com, you can search for that. So wherever you're living in the US or outside the US, we have many people all over that collaborate on HerniaTalk.com. It's a free patient discussion forum from which we're making this live session every week. And just search, there's a search function, search for Florida. There's several surgeons on that, and patients who have been to those surgeons who you can connect with to help figure out which surgeon is best for you. Okay, have you ever had mesh that arose into the vagina or the bladder wall? I think that's pelvic mesh. Although I have had one patient with, more than one patient that had inguinal mesh erode into the bladder wall, but not the vagina. Agree?
Yeah, that's, again, in those situations, I'm going to throw a little curveball. It's not the mesh that did that.
It's a surgeon.
Yeah. I mean, it's not the, listen, there was an over dissection. Either that or there was a thermal injury with energy that caused a delayed burn, and then the mesh eroded. That implant, if it's placed in the right position, is not eroding into your vagina or into your bladder. It's only going to happen if you over dissect. It is easy to blame it. Don't get me wrong. It is easy to blame it. I'm with you. Blame the mesh. I get it. But you really got to be honest and look at that operation. So have I seen bladder injuries? Yes. Have I seen mesh erode into the bladder? No, I actually have not. Not inguinal mesh, and I have not seen it erode into the vagina, but I know it's possible, but I don't think it's just the mesh itself.
Yeah, in fact, I had a patient who did have mesh erode into her bladder, and if you read the opera report, it says basically, I didn't know where I was. I kind of got into this plane. It was very confusing to me. I put the mesh in there. I think I was in the right plane. And then I inherited the patient. So in retrospect, what happened was, for some reason, the plane between the bladder and the abdominal wall was, I think she had a cesarean section. Maybe that was why. That plane was scarred in, and they ended up putting in mesh in the bladder wall, not outside the bladder. So yeah, that was a technique problem, not the mesh itself, but you know, a lot of sequela from that. Okay, we have 4 more minutes. Let's do one more question from the Zoom. It says, when I sit with my legs crossed, my left leg barely can go down, very tight, the right side no problem. I've had a bilateral inguinal hernia repair. Any idea what could cause the tightness?
What kind of repair?
Repair, laparoscopic bilateral inguinal hernia repair. Does that prevent you from being nimble?
No.
Yeah, unless you're a ballerina.
Even then, you know, I did. It's interesting. And next time you're in the operating room, Sherwin, and you're laparoscopic in the abdomen, take the leg and flex it, extend it, external rotate it, internal rotate it at the hip. The inside doesn't move. The inside doesn't move. It is super interesting. So, you know, when you do that a few times, you start to realize that laparoscopic mesh is very, very rarely, if at all, going to be blamed or related to external pain from movements, including but not limited to crossing the leg over. So if there's tightness crossing the left leg over the right hip, you really got to dissect the muscles that are being used there and get an MRI to look at them. Specifically, that's going to be an adductor. As you're adducting the leg, it's going to be slight flexion, and that's also going to be an internal rotation of the hip. And so you want to look at the hip and the groin MRIs for things that are causing that.
Because it could be a hip joint problem too, right? That gives groin pain.
Absolutely. Hips, labral tears specifically, and sometimes impingement are the #1 non-groin related cause of groin pain.
Okay, I'm going to fit in one more quick question.
Sure.
From Facebook Live. Is umbilical hernia surgery under general anesthesia safe in an ambulatory day surgery center, or should they always be done in a hospital?
Trick question. It's actually more safe in an ambulatory surgery center under general. As long as it's a certified center with a board certified anesthesiologist and an outstanding center. I think that the check-in process, the check-out process, the attention to detail are always going to be slightly, you know, a better enhanced patient experience at a smaller center than a giant hospital. That's not true for all hospitals, but I think in general that's a true statement. As far as safe, absolutely safe, no matter where you have it done.
Do you use general anesthesia for your umbilical hernia repairs?
I mean, it depends if I'm doing them open or lap.
Open.
So open with just suture, and I don't use mesh for my open, tiny little ones.
Right.
It's up to the patient. So if they're willing to be put to sleep, yes. Otherwise, it's not general. It's something called IV sedation and local.
Yeah, I try and use as much deep sedation as possible, and a good anesthesiologist is very comfortable allowing you to take the anesthesia deep without general anesthesia, so you can, I think the recovery is easier if you don't use general anesthesia. And yeah. I do that for most of my open inguinals, open mesh removals, and the small belly button hernias that are open. Not laparoscopic, you have to use general for that, right?
Sure, no, I appreciate that. It's true. And just so patients realize, when we say belly button hernias that are small, you know, everybody's different. But I think we're talking about the little ones that are, you know, common in Beverly Hills in New York City.
Yeah.
They're 1 centimeter ones.
Right.
There's a lot of patients who come in with belly button hernias that may be small, but they're now, you know, once you get to the size of a quarter, it's a different ballgame. So yes. We're talking about the ones that are the size of a dime, not a quarter.
All right, that's it for us. Please follow Dr. Brian Jacob. His practice is in New York City at Mount Sinai. He's a laparoscopic and hernia specialist. He's at NYC Hernia. on Twitter. You can also follow me all over the different social media platforms at HerniaTalk. And lastly, if you missed or want to review this is a video of this 1 hour is available on Facebook Live on my Facebook page, Dr. Tofi, and also I will post it on YouTube and let you know the link to that on my channel. Thank you, everyone. We'll see you again next Sunday at 5 p.m. Pacific, 8 p.m. Eastern, GMT plus 7 hours. Love you all. Bye-bye.
Thanks for having me, Sherwin. Stay
Thank you.
safe.
Bye.